Assalamu alaikum. Today I'll be discussing chronic pancreatitis. Okay, I have discussed that depending upon reversibility, the pancreatitis is divided into two forms: acute pancreatitis and chronic pancreatitis. Acute form is reversible form, while chronic form is irreversible form. So the chronic form basically involves irreversible destruction of the pancreas. It first involves the exocrine part, and then it involves, and eventually it involves the endocrine part. So it is irreversible destruction of the exocrine pancreas. Exocrine pancreas basically involves acini cells, which serous acini, which release pancreatic enzymes, and followed eventually by the destruction of islets of Langerhans, which are basically the endocrine part of the pancreas, which release insulin and glucagon. एंड देन वी हैव बेसिकली अब क्वेश्चन ये है कि क्रोनिक पैंक्रियाटाइटिस में होता क्या है पैंक्रियास के साथ, लाइक व्हाट इज हैपनिंग इन द पैंक्रियास एंड व्हाई इट इज हैपनिंग. ये दो इंपॉर्टेंट क्वेश्चंस हैं. सो इट इज़ इरिवर्सिबल डिस्ट्रक्शन. अब इरिवर्सिबल डिस्ट्रक्शन में क्या हो रहा है? देयर इज फाइब्रोसिस ऑफ द पैंक्रियाटिक पेरेन्काइमा. तो पैंक्रियाटिक पेरेन्काइमा में फाइब्रोसिस हो जाता है. फाइब्रोसिस की वजह से क्या होगा? पैंक्रियाटिक पेरेन्काइमा का फंक्शन लॉस हो जाएगा. तो इनके फंक्शनल लॉस है बेसिकली पैंक्रियास का. देन अब ये होता क्यों है? इट इज़ सेकेंडरी टू रिक्रेंट बाउट्स ऑफ एक्यूट इन्फ्लेमेशन. कि एक पर्सन है, ही इज़ प्रेजेंटिंग यू विद number of episodes of acute inflammation, then maybe these recurrent bouts of acute inflammation then lead to chronic pancreatitis. So basically chronic pancreatitis क्या है? It is irreversible destruction involving fibrosis of the pancreatic parenchyma due to recurrent bouts of acute pancreatitis. Firstly इसके अंदर exocrine part involved होते हैं, then eventually it leads to destruction of the endocrine part as well, which has its own complications which we will discuss later. Next आ जाता है what are the important causes. अगर सबसे ज़्यादा कॉमन कॉजेज़ की बात करें, अल्कोहल इज़ द मोस्ट कॉमन कॉज ऑफ क्रोनिक पैंक्रेटाइटिस इन एडल्ट्स, एंड in children the most common cause is cystic fibrosis due to CFTR mutation, and many cases are idiopathic as well. The less common causes include long-standing duct obstruction, which is maybe due to the pseudocyst, pancreatic pseudocyst, which is again a complication of acute pancreatitis. Then we have tropical pancreatitis, which is basically a regional form of pancreatitis because it is more common in Africa and Asian regions. Then we have the hereditary pancreatitis due to mutations in PRSS1 gene and spin K1 gene. Then last of all we have a distinct form of pancreatitis, the autoimmune pancreatitis, which is due to the plasma cells which secrete IgG4 antibodies in the pancreas and which destroy the cells of the pancreas, leading to chronic pancreatitis. So we have IgG4 secreting plasma cells in pancreas in case of autoimmune pancreatitis. So next there is a comparison between an acute and chronic inflammatory condition. Like what is the difference between acute and chronic inflammatory condition? इनके इसके underlying mechanism में क्या difference है? In contrast to acute pancreatitis, in case of chronic pancreatitis, there is pro-fibrogenic cytokines released in chronic pancreatitis. Due to these pro-fibrogenic cytokines, for example, TGF-beta, connective tissue growth factor, platelet-derived growth factor, there is, in case of chronic pancreatitis, there is activation and proliferation of the periacinar myofibroblasts. The periacinar myofibroblasts, these cells, also known as pancreatic stellate cells, these cells do what? They deposit collagen in the pancreatic parenchyma and leads to fibrosis. यानी कि ये चीज़ें, ये काम एक्यूट पेंक्रेटाइटिस में नहीं हो रहा होता. इन एक्यूट पेंक्रेटाइटिस देयर आर नो प्रो फाइब्रोजेनिक फैक्टर्स, there is not the activation of myofibroblast, periacinar myofibroblast, and there is no fibrosis. यानी कि फंक्शनल स्टेबिलिटी रहती है वहाँ पे, फंक्शनल हो रहा होता है. एक्यूट पेंक्रेटाइटिस में जो पेंक्रियास है इट इज़ फंक्शनल, वेयर इज इन क्रोनिक पेंक्रेटाइटिस देयर इज लॉस ऑफ फंक्शन ऑफ द पेंक्रियास ड्यू टू द फाइब्रोसिस वाला पार्ट ना. देन वी हैव क्लिनिकल फीचर्स कि पेशेंट प्रेजेंट किस तरह से करेगा. वी हैव एपिगैस्ट्रिक एब्डोमिनल पेन दैट रेडिएट्स टू बैक, सेम एज दैट ऑफ एक्यूट पेंक्रेटाइटिस, बट सेकेंडली वी कैन डिफरेंशिएट it from the acute through the pancreatic insufficiency, which basically occurs due to the fibrosis. there is because there is no release of enzymes, the pancreatic enzymes, there is malabsorption with steatoria, which are basically fatty stools, and then we have the fat soluble vitamin deficiency, which are basically the fat soluble vitamins that are absorbed with the fat, because there is no fat because there is no fat absorption in the small bowel, so it is difficult for the fat soluble vitamins to be absorbed, and unlike or in contrast to acute pancreatitis, amylase and lipase, they are not useful markers in case of chronic pancreatitis. जिस तरह से हम लोगों ने पीछे labs में देखा, in case of acute pancreatitis we have amylase and lipase raised in case of acute pancreatitis, and they are important serologic markers, but here in case of chronic pancreatitis they aren't important at all. Next we have the clinical feature, which is basically seen on imaging. It basically involves dystrophic calcification of the pancreatic parenchyma. In this scan you can easily appreciate the dystrophic calcification of the pancreatic parenchyma, and then on contrast studies it reveals a chain of lakes pattern. Here we can see the chain of lakes pattern due to dilatation of the duct of the dilatation of the pancreatic duct and beading of the pancreatic duct. It presents a chain of lake pattern. So on contrast studies it reveals a chain of lakes pattern due to dilatation and beading of the main pancreatic duct. So in this image we can appreciate the dystrophic calcification of the pancreatic parenchyma, and here we can see the chain of lake pattern of pancreas due to dilatation and beading in case of chronic pancreatitis. Next we have complications. So secondary diabetes mellitus. As we know, as I have discussed earlier, firstly the exocrine part is involved, which causes pancreatic insufficiency, and in later stages of chronic pancreatitis, the endocrine part, the islets of Langerhans, they are also involved, which causes secondary diabetes mellitus. And last but not the least, we have increased risk for pancreatic carcinoma, which I'll be discussing in the next lecture, inshallah. Then we have morphology of the chronic pancreatitis. Morphology, we have दो तरह की morphology, एक माइक्रोस्कोपिक, सेकेंडली वी हैव मैक्रोस्कोपिक. माइक्रोस्कोपिक में हमें वही नज़र आएगा, ऑब्वियसली फाइब्रोसिस हो रहा है तो पेरेन्काइमल फाइब्रोसिस नज़र आ रहा होगा. अब फाइब्रोसिस की वजह से एसिनाई डिस्ट्रॉय हो रही हैं, सो देयर इज़ रिड्यूस्ड नंबर एंड साइज ऑफ द एसिनाई, एंड as I have discussed earlier, there is chain of lake pattern, so we will be viewing the dilatation of pancreatic duct. So these are three main features these are three main microscopic features of chronic pancreatitis. First of all, the parenchymal fibrosis. Secondly, we have reduced number and size of the acini. Number three, we have dilatation of the pancreatic ducts. And initially there is sparing of the islets of Langerhans. So due to acinar law, in case of chronic pancreatitis there is acinar loss. Acinar loss के अलावा we know that there is chronic pancreatitis, so the chronic inflammatory infiltrate, it accumulates around the remaining lobules and ducts. अब उसकी वजह से क्या होगा? Due to that inflammatory infiltrate, there is the ductal epithelium may be atrophied or hyperplastic or exhibit squamous metaplasia or ductal concretions. These are some of the key features. Due to the accumulation of chronic inflammatory infiltrate, the ductal epithelium is atrophied, hyperplastic, or exhibits squamous metaplasia and ductal concretions. And these are the changes in the morphology which are basically increasing the risk of pancreatic carcinoma. Then eventually in the later stages, islets of Langerhans are involved, leading to a sclerotic tissue, and they fuse and may enlarge and then disappear. These are some things जो बहुत लेटर स्टेजेस में हो रही होंगी कि एट द एंड ऑफ द डे इन क्रोनिक पैंक्रेटाइटिस आपका एंडोक्राइन टिश्यू भी लॉस हो जाएगा. This was the microscopic picture of chronic pancreatitis. Next we have the gross picture. And on gross picture, the gland appears hard with extremely dilated ducts, as we have seen in the chain of lake pattern. Then we have visible calcified concretions. These are three gross changes. Last but not the least, we have autoimmune pancreatitis. We have discussed earlier, due to the plasma cells which secrete IgG4 antibodies. So we have infiltration of pancreas by lymphocytes and plasma cells, which causes the fibrosis. So it is basically a fibrotic change, also known as the lymphoplasmacytic sclerosing pancreatitis, which involves swelling, fibrosis, and venulitis. So that's it for today. Then next in the next lecture I'll be discussing pancreatic carcinoma.